is now starting. All attendees are in listen-only mode.
Good afternoon. Thank you so much for joining us today. We're so happy that you could be with us for the Center for Change webinar series. We're thrilled to have Dr. Susan Mengden with us today. I think you're in for a real treat. She's got so much to present and lots of great information. So we're excited to have her with us and looking forward to that. We have just a couple of things that we need to do prior to starting that. We just have a little bit of housekeeping. So we'll get going on that, and then we'll turn it over to Susan. So first, you will see that there's a copy of Susan's PowerPoint in the handout section of the toolbar. If you click on the handout section, you'll see that there are actually 4 handouts in there, and I'll talk about those in a minute, but that's where you will find any handouts. You're welcome to download that, and if you want to save the handouts for later, you're more than welcome to do that. That's where you'll find them, is in that section. A copy of the post-test is also in that same section. This is for reference only. In order to obtain CE credit, you must take the post-test online, and I'll talk more about that in just a minute. But if you're looking for the test, the post-test, you're welcome to download that, follow along, so that you can keep an eye on what the test questions will be when the time comes. You're welcome to submit questions in the questions section of the toolbar. So you just type in your questions. I'll keep an eye on those throughout the presentation, and then at the end of Dr. Mengden's presentation, then we'll see if we can get to some questions and I'll address those. So feel free to send those questions throughout the presentation, and I'll keep an eye out. When the webinar ends, there will be an evaluation that will automatically pop up on your computer screen. You'll take 30 seconds to complete that evaluation. That would be really helpful. It's a continuing education requirement for us. It's completely anonymous, so feel free to be candid in that in those responses. But if you would do that for us, that would be really helpful. We then tabulate that information and send it to the continuing education entities. So that would be really helpful if you could take just 30 seconds to complete that. And then the most important thing, about an hour after the webinar ends, you'll receive a separate email from GoToWebinar with the link that you click on to take the online test. Again, you must take the test online and pass it. And once you pass it, then your certificate of education will be automatically downloaded to your computer. So if you don't see it, take a look in your download section of your computer. Sometimes it hides there. So keep an eye out for that. Again, about an hour after the webinar ends, you'll get an email with a link to take the online test. Okay, I think we're ready. So Susan, I am going to turn it over to you. So give me 1 second to do that.
Okay.
Okay.
All righty, here we go.
I see your screen, so I'm going to turn off my mic and my camera, but if you need me, I'm right here. Otherwise, we'll let Susan go forward with her presentation, and I'll see y'all at the end.
Great, thank you so much, Tamara. Good afternoon. I've worked with the Center for Change for many years, and I'm honored to be here today, sharing my clinical experience and my thoughts about several of these underserved eating disorder populations. So I'm Susan Mengden. I'm a certified eating disorder specialist. I've been practicing in the eating disorder world for over 30 years, first in Boston in an inpatient facility, and then here in San Antonio in a US military facility running an eating disorder IOP. I then have also started 2 PHP and IOP programs here in San Antonio, and currently I'm clinical director of the Esperanza Eating Disorder Center. I'm speaking here today to raise awareness of the eating disorder pathology in these populations, to dispel the myths that only the young, white, wealthy female has an eating disorder. For clinicians who treat people with eating disorders, it's important that you look for and recognize the eating disorder pathology, as well as address treatment obstacles, so that we can increase treatment opportunities for these populations today. For clinicians who do not treat people with eating disorders, my goal is to provide you with information so that you can look for and recognize eating disorder pathology, and then direct individuals to specialty treatment. In a 2019 study of a 10-year literature review, the prevalence rates of eating disorders doubled. And I believe that this reason is because we are identifying eating disorders in these underserved populations. So I am speaking from a place of privilege. I'm not an expert on these populations, and I'm just speaking to bring awareness and encourage treatment opportunities for these populations. So why these underserved populations? One, I'm from San Antonio. It is the 7th largest city in the US. It is called Military City, USA. We are also a large retirement community, named the 3rd best place to retire by US News and World Report. 64% of our population identifies as Hispanic or Latinx. This is a new and developing gender-neutral term, as Latinx doesn't really make sense in the Spanish language. So you'll hear me saying that today. All the research, though, still has Latinx in it. So there are also about our city of San Antonio. We are considered one of the poorest metropolitan areas in the country. We have a 17% poverty rate. And I'm the proud mother of a 25-year-old Down syndrome female. And so since her birth, I have been referred and worked with many people with disabilities, all different types of disabilities. So we know in the eating disorder field that there are many underserved populations in our treatment centers. And I put these up here. These are not on the question at the end. I just wanted you to know that these are all underserved populations in the eating disorder field. You know, people of color are just not recognized. And also we don't have enough clinicians who are people of color. Males, about 10 million males have eating disorders, and we just don't see them in our facilities. The LGBTQ population, we believe that truly it's a risk for poverty and not having the insurance that gets them into our facilities. Native American, Asian Americans. This is fast, so you're going, because I don't want to spend time on these populations, I just wanted you to know and to have you read about them. This is the latest research on any one of these populations. I've really done extensive research on looking at that. Our government insured populations, I know I speak about this a lot, that our facilities, our eating disorder facilities across the country, only a few take Medicare. And those I'm so happy to refer to. And our Medicaid population only serves the under 18 with Medicaid. And most facilities still today do not cover the government insured. Now, eating disorders across the weight spectrum. I'm going to talk about this when I talk about the Hispanic, Latinx population, because I believe that we're just missing eating disorders across the weight continuum. We're really not identifying people with binge eating disorder. Okay, so what makes someone underserved? Well, what makes someone underserved is that they may not recognize that they have an eating disorder. And this is because we only have the myth of who has an eating disorder. You'll hear me say some of this in the military population, that their eating disorders are hidden and also really not recognized by the people who have them. There's also we know that our clinicians aren't recognizing or even looking for these underserved populations. So I'm going to be discussing the risk factors so that we can look for those. And then there's obstacles of accessing treatment, lack of health insurance, provider scarcity, providers who don't speak the language of the person who's needing eating disorder treatment, and overall poverty of people who just don't have access to care. And so we want to know how to serve them. Okay, our objectives today. Here we go. All righty. So today in this webinar, I'm going to address these 5 underserved populations. I'll present the current findings on their prevalence rates, risk factors for developing an eating disorder, and obstacles for treatment. And I've already talked about why I think this is really important for us to have this kind of information and to serve these populations. Okay, so first I'm going to talk about eating disorders in the military. Now, those of you who've seen, I've been working with the military since 1997, first at a facility, but also as a TRICARE military healthcare provider. So the military population is really large in the United States, 1.5 million in the US military in America. Active duty have a higher prevalence rate of eating disorders over civilians. And why is this? This is because of many of the procedures and regulations of the military. So I'm going to talk a little bit about those. That is a really high percentage if you look at it. 30 to 60% have eating disorders. And yes, that's what they're reporting. And the majority of that is binge eating disorder. Now, military women are 6 times more likely to have bulimia. And we know that starts in the military academies. Of the veteran population, what we see here is that eating disorders in the veteran population are associated more with military sexual trauma versus combat trauma. And dependents also. These are the wives and the children, or the husbands and the children of the military active duty members. Their rates for eating disorders are also higher than civilians. So let's look at the risk factors here. Okay, the risk factors we know are military sexual trauma. If someone has military sexual trauma, they have 2 times the odds of just a military person having an eating disorder. Combat exposure creates the stress of trauma as well, and often people cope with trauma with binge eating. But the height and weight standards of the military. Height and weight standards are twice a year physical therapy tests for fitness for duty, which affects promotions, deployments. It is based on the U.S. Army Body Composition Program that has BMI thresholds that are very restrictive and create problems for the active duty military. If an active duty military fails a height weight standard, then they are referred to a program where they are encouraged to lose weight and to overexercise. Now we know from the eating disorder field knows that encouraging restrictive dieting behavior often backfires and leads to binging behaviors. And that's exactly what we see in the active duty military. So we're looking at also height weight standards that up to 60% of the military have binge eating compared to anorexia. So that's the eating disorder we're looking at, is bulimia and binge eating disorder. Height weight standards affect the female active duty after giving birth. And what we see in treatment is when we work with with our active duty. We know that for them to be successful in their career, they have to meet a certain body tape measurement. They have to meet, like I said, a certain height, weight standards. And so they are encouraged by peers in the military to engage in compensatory behaviors, such as, purging after every meal, so that they can make weight. And that is the term for it. A third of our overweight vets have been using compensatory behaviors when they were active duty to make weight. And now that they don't have the exercise requirements, or they just can't stop the behaviors because they have now developed an eating disorder. They also may not even recognize that they have an eating disorder, and they certainly don't want to talk about having an eating disorder, because we do know that if they have an eating disorder for longer than 3 months, and it's documented for longer than 3 months, then they can be separated from the military. And I'm going to the next slide already. So let me talk about the dependents for a moment before I get there. The dependents, basically what I have seen over the years is that the dependents' eating disorder behaviors often are affected by watching their parent or spouse engage in eating disorder behaviors in order to make weight. Also the underlying situational dynamics of the multiple moves that the military can have, the stress of a spouse being out of country, or you being out of country, and really in the children, loss of control as they move, often every 3 years. They lose their support systems. The wives or the husbands can also lose their support systems. The active duty member has a new support system, but the dependent often doesn't and loses their job and has to start all over again. So this is very, very stressful. So here we're looking at treatment and resources. I jumped ahead earlier and looked and talked about how an active duty member with an eating disorder can be medically boarded. Now, if they want to be medically boarded, this is wonderful for them, and then they'll truly engage in treatment and want to use the skills needed in order to stop the binge eating and the purging or the compensatory behaviors. But if they want to remain successful in the military and they don't have the body type, then they're going to have that pressure to maintain their symptoms. And I know those of you who work in the hospitals and in the residential facilities can see that often the active duty personnel is not motivated for treatment unless they are going to be medically boarded or separated from the military. Now also there's limits of confidentiality. Your command knows everything you're doing and what your eating disorder is. The obstacles for the command is very interesting for those of you who are just beginning to work with the military. The military really does have limits of confidentiality, and those are well known to the active duty person, and then you try to maintain the confidentiality as well as you can in order to help them. Obstacles for veterans. The VA programs have talked for years about needing eating disorder programming and training. Still to this day, I think that they are working on that and haven't done that yet, still referring people out to the communities. And as I said earlier, the obstacles for veterans is that the eating disorder behaviors occur later in life, continue after someone has left active duty treatment or active duty status, and we have someone very entrenched in their eating disorder behaviors then, and that just makes it much more difficult. The obstacles for dependents are two. If a child or a spouse of an active duty has a documented eating disorder, that can negatively affect the career of the active duty personnel. TDYs are limited if it's not next to a major facility that has an eating disorder program in it. So those are few, and often then that adds to the shame of the person with eating disorders, and such family disruption as well. Also, looking at military insurance. Until recently, the military did not cover residential levels of care, partials or IOPs. Initially, the military insurance just covered inpatient hospitalization. So now that is different. Some of the programs around the country that are residentials take the military insurance. So that is wonderful. Outpatient level of care for dietary management. In the facilities, there is no training for the dietitians with eating disorders. And the military insurance, at least here in San Antonio, is not covering outpatient dietary services. And it really needs to for eating disorders. Now, TRICARE, Medicare TRICARE, this is TRICARE for life with someone who has either retired and is on, in the VA status, or who is disabled that has Medicare primary, TRICARE secondary. The tricky thing here is that if Medicare doesn't cover the person's treatment, then TRICARE doesn't. It is a little different from, if the primary insurance doesn't cover, the secondary does. That is not the case with TRICARE for life, which puts people in a big, dilemma. Also, another thing, if someone is a young person who wants to enter into military service, if they have a documented eating disorder for over a 3-month period of time, they are medically disqualified from access into the military service. So even if they have recovered from an eating disorder, they're disqualified from entering. So what does this do? This just has people lie about it and maintain their eating disorder behaviors. Okay. So before I go to the next slide, what the information I'm hoping to give you today is there's a higher prevalence rate in the military and in the veteran population. Look for binge eating and for BED and bulimia, and the motivation for the person who is active duty is low unless they're being medically boarded. So you have to do a lot of motivational interviewing and a lot of work with them. We do that, I think, in the military partial programs. We do a lot of work looking at what are the costs for you for maintaining this eating disorder behavior. Your career might be just great because now you can, hit the height weight standards, but look what you're doing to your body and look what you're setting yourself up for. And oftentimes people actually say, okay, you're right, I'm tired of this eating disorder, it's affecting my health, and now I'm going to look for a different career. Okay. Now we're going to talk about eating disorders in the food insecure population. Okay, what does food insecure mean? This is such a new focus of treatment. I'm very excited about this. The definition of food insecurity is inadequate access to sufficient food, both in terms of quantity and quality. And it's secondary to lack of financial and other resources. So it's highly linked to poverty. So a study was done here in San Antonio by Carolyn Becker of Trinity University at the San Antonio Food Bank. with 503 individuals, and then it was replicated with 850 more individuals a year later. So this is what we have found here in the food insecure populations, that 17% of those with food insecurity have been getting their food from the food bank. 17% met criteria for an eating disorder. And which eating disorder? The binge eating disorders. 38% report binge eating. Of those 17%, 38% report binge eating, 38% report night eating when everyone is asleep, except for them. 20% report vomiting to control weight and shape, and 23% report laxative use. Food insecurity, because it is associated with the binge eating, is associated also with obesity. And the most severe level of food insecurity is among adults who report having hungry children. And that is over the household, okay? The household hunger is a different level where everyone in the house is hungry. The hungry children, where there are children in the house that are hungry, and doesn't that make sense, are more distressing to the adults. The compensatory behaviors, as I said, are there to either hide the binge eating or to prevent weight gain from the binge eating. Now, this is an interesting finding as well, that 55% of those with food insecurity have directly experienced a traumatic event. So looking at the weight stigma, anxiety, depression in this population, we also look at the fact that some of the compensatory behaviors are about the internalized negative social attitudes about heavier bodies and the prejudice about overweight status that we have here in our country. So treatment and resources for the food insecure population. We know already that there's a lack of health insurance in this population. And I want to talk a little bit about this. Government grants have been coming or have been funded to different cities and metropolitan areas that have a large food insecure population. And I just want to say these are wonderful. They're awarded to fight obesity though. They are unaware and do not address the mental health issues of binge eating pathology or the treatment. Therefore, these grants, which address and encourage dieting behaviors and overexercise, may only have increased the internalized weight stigma and shame associated with the binge eating. So I want us to, if anybody out there is watching that has any, any access to the government grants that are coming into the cities to help them with the fighting obesity, I'm hoping that you will say, boy, we've got to look at eating disorder treatment as well and mental health treatment of the anxiety, depression, and the trauma. Okay, now I'm going to talk about eating disorders among the elderly. Okay, I know I'm going fast through these guys, and so at the end we will have questions, but also please feel free. I have my email on the slides, and you can certainly email me questions and I will respond. Okay, so eating disorders among the elderly. So the prevalence rates. What we're seeing is that, first 10% of us women are over, in the US are over 60, and I'm one of them. And our inpatient admissions for eating disorder treatment over the age of 40 is increasing. We've certainly seen that here, especially in our binge eating populations. From 1999 to 2009, hospitalizations for people increased by 88%, and 13% of women over 50 are engaged in disordered eating behavior. another 20% over 70. So our diet mentality and our weight stigma for our country really lasts with people. It's not like all of a sudden you turn 60 and you love your body, or you feel like, okay, great, I don't need to change something about my body. We realize that these messages that we've been getting all our lives continue to drive people's eating behaviors and body image disturbance. As someone ages, we know that laxative abuse becomes the most common form of purging, and I believe just because it is easier on the body than the vomiting. But this is a dramatic bullet point here. 78% of the deaths due to anorexia, for those of us who are eating disorder professionals, we know that eating disorders are the most deadly of all the mental illnesses, and 78% of them occur among the elderly. And that is because the body is tired. Often the body is going up and down in weight and has had behaviors that have affected the heart for years. So what are the risk factors among the elderly? The number one risk factor is body image. And now we can go on all of our social media and social cultural, the thin ideal, the pressure to look young and thin. This is what is driving the eating disorders among the elderly. Depression, as we know, depression is even higher this year in all the isolation, and the isolation that has also happened in our nursing homes. Losses, deaths. We've had a year of that, last year of that. Stressors, divorce, deaths, like I said, of significant others, illnesses as we age, cancers, and living in a nursing facility. We also decrease our physical activity and decrease our eating behaviors. And sometimes that really kicks off a deprivation for people, depending on what their history is. Like I said, I could speak for an hour on ageism and cultural standards of beauty. And looking at that, we know that we need to look for eating disorders among our elderly population. And not just women, but men. The reason that the diagnosis is not recognized is because there's still the myth, like I said at the beginning, that eating disorders are only among the young. And as I've shown you, that is just not the case. So what we're seeing here, before I leave this area and go to another underserved population, is there are three primary presentations that they have seen in our research. And there's been very little research done on the ages 60 and older. But what we've seen is that there's three types of presentations that you might see. One are people who've suffered since adolescence and didn't receive help for whatever reason. Maybe didn't want help, or the symptoms weren't bad enough. But you can see someone with a very, very entrenched eating disorder. Or people who had a recurrence of an eating disorder based on losses, based on life situation, developmental issues, or people who've developed an eating disorder later in life and have had no history. Now, I have seen a few people like this who've developed an eating disorder later in life when they've had a tremendous loss, something, they've either lost a spouse or a child, and their eating disorder becomes a coping mechanism. Once again, we know that eating disorders as coping mechanisms are easier when you are a functional person. You can, or the binge eating disorders are, you can binge eat and purge or not and continue to be successful in work. So often we will see someone like that. However, I have mostly seen people who are, who never really had problematic they've had their eating disorder for a long time, but they didn't have the problematic medical complications, or they ignored them. And then are very excited, but had no knowledge that you can recover from an eating disorder. So in your practices, if you're working with someone who is older, or that you've had someone older come into a hospital or a residential program, you can offer them the hope of the new third wave cognitive behavioral therapies that have been found to be so successful with eating disorder recovery. So please look for them and give them that hopeful message. Okay, so now we're going to look at women with disabilities. Okay. Women with disabilities. So first I'm going to talk about body image. Is one of the underlying core issues and symptoms of eating disorders. Most of the research, and let me tell you, we have really looked up this research lately. Most of the research on body image is on the able-bodied and with people with normal to high intelligence. So this creates a real problem for us in the treatment world. We need to modify our treatment approaches. And so I'm going to give you some of those examples. So here, let's look at the prevalence rates first of people with disability in America. 1 in 4 women have a disability. 26% of adults in the US have some form of a disability. The highest percentage of disabilities is in the South. I do not know why. And of those with a disability, 8 to 10% have eating disorder pathology. Women with physical disabilities have a high risk due to body image disturbances, lack of control, and medical weight loss recommendations. And I'll go over that in the next page. Okay, for the physical disabilities, we have 13% have mobility, 5.9% hearing, and 4.6% vision. These are disabilities with eating disorders, or eating disorder percentages in those specific disabilities. Now, one of the things they're looking at in all of these studies is that mostly they're looking at the obesity rate, and people with physical disabilities are more likely to be overweight or obese by a chance of 12% higher rate than the regular country. And that is because of the limitations on movement. And cognitive disabilities, I'll talk about in a case study in a moment. Okay. The risk factors, like I said, are body image disturbances and weight concern due to mobility. So from the moment someone has a physical disability and is possibly in a wheelchair, there is a weight concern due to being able to transfer, having someone being able to help you and attend to you physically. So there is often the weight loss recommendation and the monitoring, which we know right away affects body image. There is the appearance idealization, where someone will wish and hope and spend a lot of time suffering, wanting to look like the able-bodied Northern American, Northern European body, and have to do work, eating disorder body image work, because we're the field that does that body image work with people who are not liking their bodies and therefore change their eating patterns because of it. Often people who are have a disability, whether they are hearing impaired or vision impaired, are often bullied about their bodies. And we know the effect of that. That creates shame and disordered eating in many cases. Also, we look at eating disorder as a way to cope. When there is a lack of control, resulting from the need for assistance. You know, when someone is giving you a bath and you're 25 years old and helping you, that is often an embarrassing place to be. And so focusing on what they're eating or what they're not eating is a wonderful way to cope for them. Healthcare providers and the weight loss mentality of physicians, all the healthcare, talking about your weight to you, recommending weight loss, recommending dieting behavior. We know a lot of this sets up people with disabilities for risks. We do know that many of the eating disorder facilities across the country, if someone has insurance, they are ADA equipped to work with people in wheelchairs or with vision or hearing impairment. And so people can get treatment in eating disorder facilities. Are they recommended for treatment by outpatient healthcare providers? Often not, because I believe that the questions aren't being asked about their eating behavior. It's not, you know, a diet behavior. So like I said, dieting is strongly encouraged, and males with disabilities have not been researched. The poverty level among those with disabilities is high. A lot have the Medicare insurance, and like I said, then that limits the facilities that you can go to. And most facilities, eating disorder facilities, do not take Medicare. And of the 20 that do across the country, you know, you still have copays. And so these people can't access treatment. So now I'm going to talk a little bit about what I have learned as a mother of a young woman with intellectual disability disorder. There is no treatment identified to date for eating disorders. And people make the assumption that just because someone doesn't have a normal to high IQ, that they don't have feelings when you talk about their body, or you have weight stigma and you are worried from the time they are born that they're going to be overweight or obese. And that is one of the things that I just want people to realize, that people with a low IQ still can respond and be affected horribly by body image disturbance. So watch what you say to people, treat them just like everyone else as far as what you say about them, which is, as we know in the eating disorder field, let's stop the body talk. People don't need to hear what you think about their body. And so educating parents and healthcare providers is something that I think would be really great with the IDD population. Now also, all of our wonderful third wave cognitive behavioral therapy treatment approaches are really not appropriate for those with a low IQ, low to moderate, even some of the below normal IQs. So instead, behavior management is really recommended. Is there research on this? Like I said, no, but I can say that in case studies I have found, because I've been referred people over the years, because like I said, I have a daughter with Down syndrome. I've been referred people, and then you can work behaviorally with the family of, helping someone move their body in joyous ways, and helping people also not overeat. And eating is enjoyable for people. And if you monitor the eating behavior and in a way that is respectful and not controlling and not limiting and not saying you can't eat that because you've got to go on a diet, you're eating too much, you've gained too much weight, you're too fat, You know, if you don't say things like that, then you're not setting up that deprivation, and you're just having, you know, regular meals, and go to, you know, if you need to, because you possibly will, I always recommend the parent to go to a eating disorder dietitian, get a meal plan, and then be the one, just like in family-based treatment, the parent is the one who serves the food in the house and monitors it at school or in day programs. Okay, let's keep going. Thank you for my my strong feelings about that one. So eating disorders in the Hispanic, Latina, people of Latin American descent population here in America. We know that the Hispanic population in America is the highest of the ethnic cultures in America, making up 18% of the US population. And I've got a lot of feelings about some of the things that the white culture has influenced in this population. So I will be discussing those in and out of the prevalence rates. Now, obesity is one of the most prevalent weight-related concerns among this population because of the binge eating or the overeating, which also is influenced by the food insecure population or some other stressors, which I'm going to talk about in just a moment. We do know that eating disorders, obesity, and diabetes also are linked to each other. And the prevalence rate of diabetes in the Hispanic Latina population is 11.8 or 12% of that population has diabetes. And they have gotten such a bad rap. We know that this can be genetically transferred from one generation to another. Type 1 diabetes is part of this 12%. And so us in America giving our thoughts about dieting and how someone of this population needs to start dieting as a young person just dramatically affects them and can result in an eating disorder. So in the research, we see that the prevalence rates of anorexia are low, and I believe because we're missing the boat there. When you look at someone with anorexic behaviors, I realize that they're then becoming a different eating disorder other than anorexia. But often we see anorexic behaviors in someone who is in a larger body. And genetically, they have some of the populations that make up the Hispanic population are of shorter stature, and so can end up in a larger body and have anorexia behaviors. So let's not make assumptions that everyone in a larger body has binge eating, because that is often not the case. Now, there are rates of binge eating, which I believe are also related to, well, we're going to talk about acculturation, stress, and food insecurity. So the body image dissatisfaction, for years, we thought, oh, the body image dissatisfaction of the white culture is, you know, the Anglos, where ours is so much worse because we're comparing ourselves to the models on TV and to other whites. And that, oh, different cultures are not comparing themselves to the white person. And that is not true. We have found in research that it is a similar body image dissatisfaction. When we have glorified a certain body style, everyone who has acculturated is now looking to look like that body type and style. So, treatment, and like I said, I'll talk about acculturation, stress, down there factors influencing treatment in a moment. But cultural considerations for treatment. I'm going to talk about this for a little bit. In our consideration for treating someone who is Hispanic or Latina, we truly need to look at what has happened to their culture and to the foods of their culture. The types of food that they eat have been influenced by the fact that there are often large family. Often the primary food provider is the grandmother. Grandmother buys affordable foods for the family, which has sometimes not been fruits and vegetables or fish. Parents are working. There are holiday foods that are different from the Anglo population and are important because they bring the family together. Many of their cultural foods have been labeled bad. And then that sets up a whole rejection of their culture instead of eating foods in balance. Family roles. What I have in here is family roles for treatment is often you're going to be working with that grandmother and not the mother who may be feeding the family. But you've got to find out and ask who's feeding the family and where does the food come from? And let's look at that. We forget to ask those questions. And then we disrespect that culture and we can often lose them in treatment. So we do need to be aware of that. Family needs are over the individual needs, which means that if the family needs income, then instead of going to treatment, you might need to be working. And so often that is the pressure of the young, especially the oldest of the young. Beliefs, like I said, that, that religion, prayer can heal you. There are folk healers in the Latin American cultures and the Mexican American cultures, and diet culture. Gender roles of maleness and of femaleness, which is truly, if a young female has the pressure to be a homemaker or taking care of the rest of the family, they also are then encouraged to diet. And the entire family can encourage them to look a certain way so that they are more successful in their work. So the medical model of weight management is often what we see when someone is of a larger body type. Oh, let's have a medical weight loss. Factors influencing treatment. Now here we go with the acculturative stress. What that means is assimilation of a different culture into one's own culture. That's the thin ideal, trying to look like really a Northern European with the skin color, the hairstyle, the body shape and size. So this means that also we have we have the recommendations from healthcare providers when someone comes in as a young person that is already recommended to lose weight. And we see that over and over again in our young 10-year-olds are recommended to lose weight instead of giving them healthier or encouraging movement, not the dieting. Okay, language. Few of our healthcare providers in our eating disorder facilities are bilingual. We know that inadequate financial resources keep people from treatment. Access to treatment is low, which means that there are many small cities in America that don't have eating disorder treatment in them. So it's wonderful to have the virtual world. And stigma about mental illness. We do know that in the Hispanic culture, there is a stigma about seeking treatment for a mental illness. And an eating disorder is considered a mental illness. So often in the, grandparent, parent age, there is that stigma. Certainly not in the younger populations now, but they are still affected by someone in the family discouraging them from treatment. Acculturation also impacts, one last thing, weight cycling. So we see a lot of weight cycling in this population. So I have now gone rapidly, very, very rapidly through this slideshow. So I'm going to open up to some questions, and we're going to continue with that. Please know that I am happy to answer questions.
I am back. Great job, Susan. That was awesome information and a ton of it. So thank you for that. We have a couple of questions. The first one is from, let me click my box real quick. There we go. The first one is from the military section. And this person says, I'm a private practice dietitian serving persons with disordered eating. What is the best way to connect my services with active duty / veterans and their care providers?
Oh, good for you. I am thrilled you want to do that. It's difficult. The way I did it was, and how I recommend people to do it, is to contact the military insurance and get in network with them. And once that happens, then you are referred to.
Perfect.
Calling into a military base is too difficult.
Say that again, Susan. I'm sorry. I think I stepped on your comment.
I was just going to say, calling into a military base won't connect you.
Right.
You have to go through
the personnel changes so regularly that it's, even if you get a contact today, it may be a different person tomorrow. So working with TRICARE is a great way to go. Thanks, Susan. The other one is a comment, but I thought maybe you might want to address the comment as well. This person says, oops, hold on. Now I'm getting more questions. So my comments are moving. Hang on. Folks with disabilities are more likely to experience abuse / trauma, which seems to be the unifying theme across all of these groups, as well as historical trauma.
Absolutely, that is true. Disabilities, we know that there's a higher prevalence rate of trauma in the disabled population, both the IDD and the physical disabilities. Great,
thank you. We have a couple of folks who have commented that there is some VA options for eating disorder treatment. There's 20 VA ED teams in North Texas. I have a dietitian who's indicating that, and then a military provider at TAMC, and they have an eating disorder program there. So folks might want to be aware of that.
Great, thank you for getting that information out.
Yeah, you bet. And then here's another question. How can other mental health providers best support eating disorder treatment? What do we need to know about the most successful approaches?
Well, there's so many good treatment approaches nowadays. The third wave cognitive behavioral approaches of DBT, CBT, and ACT are very successful treatments for eating disorders, in addition to the multidisciplinary. So make sure if you are an outpatient provider that you work with a dietitian and a physician, a psychiatrist if needed, and then provide the one of those treatments. And there's wonderful workbooks that you can access and use with your clients.
That goes right into the next question, Susan. Someone is asking about, there's some research, but there's not a lot of information. So for all of these diverse populations. So their question ends up being, are there books, websites, podcasts, resources you can recommend that clients could utilize as well?
I don't know. I know
I'm sorry to end on a question where I don't know.
I know we spent a lot of time really looking at the research on these different populations. And like I said, I listed a whole bunch of more populations that we're going to start working on here that we would be happy to present in the future on those other populations. there are not really books on these populations. There's a few on males with eating disorders.
Yeah.
That's
Okay, great. And then the last thing is just a comment saying, thank you for highlighting the impact of asking people to, quote, recover to a standard of white, able-bodied metric. That was, yeah, it was a great highlight for me as well. So I appreciate that. Okay, so we need to wrap up, but I will just give you a couple of quick reminders. Those of you who are attending, when the webinar ends, please fill out the evaluation that pops up on your screen. It'll only take you about 30 seconds or so to complete that. Again, that's a continuing education requirement for us. Your name is not attached to that. That information is confidential. So please feel free to be straightforward and honest with us about how you feel like the webinar went. And if you have suggestions for webinar topics in the future, it'll just take you a minute to fill that out. When we close out the webinar, it'll automatically pop up. And then about an hour from now, you will get an email from GoToWebinar, similar to the email that you received when you registered, the confirmation email. This will be a separate email from GoToWebinar with the link to take the online test. Once you take and pass that test, then the CE certificate will automatically be downloaded to your computer. So if you don't see it right away, take a look in your downloads folder. It might be hiding there. Thanks again, everybody, for joining us. My thanks to Dr. Mengden, my friend. We've been friends for years, and I'm so happy to have my friend on doing a presentation for us, and we're just thrilled that you could join us, Susan. So thank you so much, and thanks to everybody who was with us today. Everybody stay well and take good care.